Good afternoon. Welcome to the virtual town hall for July 17th. For the duration of this meeting, we have suspended our mask policy for speakers here in the auditorium so you can better understand us, and we continue to all practice social distancing. Thank you for joining us. We have a full agenda today, as you can see, where you'll hear from myself on the Economic Recovery Plan and from the Executive Vice Deans with updates in their respective areas. If you do have questions during this session, please put them in the chat box and we can address them during the Q&A or in the facts which will follow next week. Before I start and begin talking about our current situation and where we stand with our finances, I want to take a step back and provide some context. I believe that I share with you our most important goal: to ensure that Michigan Medicine will experience long-term, sustained success in all of our missions and to maintain the balance of these missions. This is also the goal of President Schlissel and the Board of Regents. During my 35 years in academic medicine, I have had the privilege of, as many of you, participating in all of our core missions: patient care, research, and education. And I, like many of you, have a passion for each of those. This year, to preserve these missions and our mission balance, we had to make very difficult, wide-ranging, decisions rapidly, in large part due to the impact of COVID-19, the pandemic, and this was on top of an already stressed environment of academic medicine. The need to make changes rapidly is unprecedented for me, and I think for most of us. The changes we've instituted and implemented have raised many questions, and I would say appropriately raised many questions. It starts with understanding how we maintain excellence and balance in all our missions. Doing so requires financial planning. Our running 5-year financial plan, which we call the Strategic Financial Framework, or SFF, is updated annually. And for several years, we've recognized that in order for us to make needed investments we've all agreed upon in people, in programs, and in capital, we need to have ongoing health system operating margins of at least 5% for the next 5 years and probably beyond. It is this healthcare margin that supports all of our academic missions and all other missions that do not generate sufficient margins in and of themselves, and in large part require financial support to achieve and maintain excellence. Before the pandemic, we were on track. However, with the pandemic, we suffered immediate, devastating losses and had to cut expenses immediately. Beginning in mid-March, we lost money every day until May. This is the health system. And as you can see, the per-day loss in blue. At the height of the pandemic in April, the health system was losing about $3 million per day. Based on projections that were made at that time, the health system was expected to lose between $130 and $230 million for fiscal year 20, which we've just closed. And we expected these losses to continue in fiscal year 21. More recently, we know that our projections have changed. We've received government and state funding that help offset losses through the CARES Act and the Michigan allocation to providers. This helped us dramatically with a total of $118 million. But as you can see from this slide, that amount is only a fraction of our total losses. I've been asked many times, with our budget improving, why do we need to continue the cost-cutting initiatives through the entirety of fiscal year 21? Well, if you look at this diagram, if you look at this graph and compare our current projections, which are in the blue bars, showing a loss for the current fiscal year of $21 million. If you compare those with the yellow bars, which are our projections in our strategic financial framework, by July 21st, without further intervention, we would have an overall deficit of $340 million. Not achieving our return on projections would put our ability to fund all our missions at risk for multiple reasons. First, health systems are rated by agencies such as Moody's and Standard & Poor and must maintain days of cash. Generally, the leading systems, highly rated systems, is greater than 200 days. A day of cash is what it costs us to operate our health system for one day. In our case, in excess of $11 million. Without our expense reduction plans, our days in cash would have been cut to less than half of our current. Falling behind our days of cash puts our bond rating at risk, and that's the rate we have to pay to borrow money, and it could limit how we make investments in the future. Here it is our excellence in all missions and our mission balance that make Michigan medicine truly outstanding and truly unique. And not addressing this now simply kicks the can further down the road, so to speak. If we don't make major changes this year, next year the gap will be larger, and ultimately we will have to make decisions that would permanently damage our academic program. In my view, this is the wrong way to go. With the actions we have in place, we believe we can close the gap and fund all missions into the future. But we face many unknowns. We don't know what will happen with COVID-19. The current continuation of the current trends or exacerbation would dramatically impact us again. And we're, all of us are having to deal with increasing strain and the need to adapt to new ways of providing care in a safe environment for everyone who works at Michigan Medicine. Earlier, I mentioned that we need an ongoing health system operating margin of at least 5% in order to fund our SFF. To return to physical health, we need to continue expense reductions through FY21. There is no simple or painless way to reduce these expenditures to make these expenditures to this reductions to this degree. I know this, and you know this. At the end of the day, all of us, all of you are the answer. But to be effective, we must understand how we can maintain our physical and emotional health, our equilibrium. We're in a crisis, and we have been for months, and this has taken a toll on every single one of us. Navigating life's challenges has never been easy, but today we all face additional and exceptional stresses at work and importantly in our personal lives. As we adapt to today's circumstances, we must learn how each of us perceive emotional and physical distress and strain, and understand and endorse our need for support and help, and our need to unplug from our stressful lives. It's okay not to be okay. Taking time away and spending time with loved ones and really disconnecting from work can make a huge difference. And I want to give you my own personal recognition of this. I've known that burnout and stress has been a major issue for many of us for a long time. During the pandemic for 3 months, like many of you, I didn't take a day off. I worked most all days in the weekend, so much so that the weekend and the weekdays blurred together, and I wondered what was going on in my mind. My wife had been in North Carolina. We have grandchildren there that their parents both work, and she was providing care for them. And I hadn't seen any of them for 3 months, and I wanted to go there for a visit. I initially said, I'll just make it over a weekend. She said, no, come for a week. And I did that. And when I returned, I realized how much better I felt. I hadn't realized the emotional stress that I was dealing with. And if I needed any further evidence, one of the security guards, we get to know the security guards as you do, mentioned to me early upon my return, what's going on? I thought, what do you mean? He said, well, you've got a bounce back in your step. You seem happier. And truly I was. And I had no idea that was as clear to others as it was unclear to me. So as leaders, and for all of us throughout our large organization, we must recognize this and encourage each other and all those we work with to be transparent with our needs for support and our needs for unplugging. It's not a sign of weakness. It's a sign of wisdom to understand how to best take care of ourselves so we can be excellent in what we do, whether it's as a healthcare provider, an educator, an investigator, or whatever is your passion. Now is our greatest time for civility, respect, inclusion, and equity. Now we have our greatest need to eliminate discrimination and develop our culture of anti-racism. We're convening an anti-racist steering committee to address all of these that affect the climate and racial disparities at Michigan Medicine. I ask that you stand with our community and do what is within your sphere of influence to be an anti-racist. Let me close by saying we should all be incredibly proud of what we have endured and how we have mobilized to manage the pandemic. You all have my admiration and appreciation, all of you, everybody in our organization. I want to express my sincerest gratitude to all of you for your incredible selflessness, innovation, and adaptability. Now I'll turn it over to David Spollinger. And put back on my mask.
Good afternoon. Thank you, Marshall. I have just a couple updates to provide today. One is really just an update on where we stand with COVID today, and then two is related to some planning that we've done in anticipation of another surge or uptick in COVID activity. And I want to thank Jeff Desmond for his slides related to the state of COVID, and for Hitinder for his planning activities on the planning to deal with COVID going forward. So I know this is hard to read, but I will just give you a couple updates. Currently, at least as of 3 days ago, we had 9 positive or PUI COVID patients, and we've sort of hovered between 5, and I saw one day where we got up to 12. And in general, it's remained in that area, though we have seen a little increase in uptick of patients coming to the emergency room, and we've seen an uptick in the positivity of tests within Washtenaw County. And of course, we're watching anxiously as the nation, and as Arizona, California, Florida, and Texas go through a upsurge of activity. And we're all concerned about what will happen going forward. And I will say that, we are a little bit concerned, obviously, and I know that people have been concerned about what our plans are. I will also point out that our occupancy has, we are running around, I think, 97% occupancy 2 days ago. This is 90% as of the 14th in UH, and I know yesterday Mott had high occupancy for all ICU beds. So we are getting back to significant activity, and so we are worried about an uptick in COVID. Just to give one example of how activity has come back, this is the surgical activity over the since March, and you can see where we were at the beginning of March, the blue line, and then the I think that's orange line from the previous year, and then the sudden ramp down that we went through during the COVID, and then as we begin to ramp up, we are now close in the last 2 weeks since July 4th. We were actually ahead of or on target with where we were a year before. The one thing that really concerns us, and this is total hospitalization in the US, is, and this just shows through July 7th, you can see the rapid uptick And if you're listening to the news, you're hearing that every day is another record, right? Whether there's another record number of cases, another record number of hospitalizations, and you've heard about Houston and other areas that have just run out of ICU beds. So I think we're all concerned about what will happen going forward. And so we need to plan for what might happen. And this is, I would say, is our situation. We must make operational decisions and prepare for both COVID and non-COVID patients going forward. I will say ramping down and focusing on COVID was hard enough. But there were consequences to not being able to delaying of care in the non-COVID patients. And so if COVID begins to come back and we have more cases, we need to be able to balance both COVID and non-COVID patients so that we can limit the morbidity and mortality. We know that there were at least a couple deaths related to delayed care, and I myself had one of my patients who had significant morbidity because of delays of care during this period of time. So I think, we're all trying to balance this going forward. And our principles will be, we still need to make sure that patients and employees are safe, and we need to balance those needs. The way the planning has occurred is to think of it in 3 different phases. One is the chronic plateau phase, where we are currently seeing patients somewhere in the 5 to 15 range, and we can handle them fairly easily if we remain on the plateau. But we know that there's likely to be acute cluster outbreaks where they're just one recent one hasn't really led to a large volume of patients yet, but in Saline after a party over the 4th of July. But you can imagine that there'll be outbreaks where there might be a large group of patients that need to be hospitalized. And then, of course, what we worry about most is if there's a resurgent pandemic and large numbers of patients and large needs for our ICU beds. So what the team that's been working on this planning has come up with is both a summer plan and a winter plan. Now that's, why wouldn't you just come up with one plan? Well, the challenge is, in order to take care of COVID patients, we have created negative pressure rooms. We have vented the air out into outside through HEPA filters in order and keep the room's negative pressure. Now that works fine in the winter and in the spring and the summer because we don't have to dehumidify the air and we don't have to cool the air. But during the summer when it's hot, we have a limited ability to create negative pressure rooms in the D wing, and so we only have 15 ICU beds during the summer because of this challenge with our facilities and chillers. So you can see we have a summer plan which says the chronic plateau we can handle right now, and we can handle acute cluster up to about 23 ICU beds needed, and that's by adding an additional 7 beds and some 4 beds in CVC 5 to cover ICU COVID patients. But if we're going to exceed 20 beds, then we're going to have to reopen the RICU in order to manage COVID. So that's the summer plan. Fall, winter, we have a little more flexibility. We can make 43 rooms negative pressure and we can come up with 43 ICU beds negative pressure. And then if we have an acute cluster, we can probably handle that. But then if we have a resurgent pandemic, then we will have to open the RICU. Now we are monitoring, influenza-like illness, COVID-like illnesses, and looking for a 3-day rise as an indicator. We're looking at local COVID data. We're looking at ED and outpatient COVID test data and overall ICU and general care census trends in order to make a decision when we have to open, the RICU. In the summer, if we anticipate exceeding 20 ICU beds, we will then open the RICU. in the fall or winter, I think it'll be closer to 30 beds. We'll have to open the RICU, get ready at 20, but open if we get to 30. And then, of course, that displaces other care in children's and women's going. Now, there is, as we've been planning this, we've also feel like if we can limit, if the plan includes a limit in the number of SICU beds that we use. And in order, we do that in order that we can maintain some of the critical surgical procedures that patients need. And we feel we can probably accommodate 90 to 94% of our usual average by limiting the number of SICU beds that are utilized by COVID patients. And so that's sort of our plan to be able to manage both COVID and non-COVID patients going forward. Before Steve comes up to talk about research, I have one last thing I want to say, and that is, we're all concerned about, trying to control another surge, or trying to tamp down the current, increase in testing, increase in positivity throughout our state. And I know the governor has made a executive order to mandate masks in public areas and others. And I'm just encouraging people that wear masks. I mean, that is the one lever we have left. If there's any chance for kids to return to school, if there's any chance to continue to have our economy slowly recover, we need to be able to tamp down the activity of COVID. This isn't political. This isn't a violation of rights. It is really about protecting all of us so that we can, move ahead as a nation. Thank you. Steve.
Thank you, David. It has been said that not everything that is faced can be changed, but nothing can be changed until it is faced. I don't need to tell you all that are watching today that we all have been faced with a lot of changes in our life, but I can tell you how proud I am to have been able to face these changes with the leaders at Michigan Medicine, both in the clinical arena, in the academic arena, in the education arena. We've set what we believe are extremely logical policies to address the needs of our patients, our learners, and our researchers. What I'd like to share with you today is how we have strategized a ramp up of our research labs. And what we tried to do was to align the ramp up with the phases that have been set by the executive orders coming out of the governor's office. You all probably know that the state of Michigan has a safe start phases. There are 6 of them, going from uncontrolled growth to post-pandemic. Currently, Washtenaw County is in the improving phase, and there are certain counties in Michigan, especially in the Upper Peninsula, that are in phase 5, the containing phase. These phases are dictated about what happens with the disease, what do we need to be safe, and what work can we do. And in the Office of Research, we've used these safe start phases to align them with areas of how we've ramped up our research activities. In the beginning, when the state was under uncontrolled growth and persistent spread, we've shuttered basically our laboratories and only had essential and critical research operations ongoing. And also those research activities that were addressed at understanding the mechanisms and translational and potential clinical implications of addressing the COVID infection were allowed to proceed. Dry lab and office space were restricted to be conducted remotely, basically from a home office. And the human research was only allowing initially tier 1 studies. And tier 1 studies are those clinical trials that potentially have life-saving drugs that are involved in clinical trials, such as treatment of blood-borne cancer, such as leukemia. We also added tier 1 clinical studies, which would be an example of developing a new treatment for a chronic disease, which currently has a suboptimal therapeutic effect. We are currently in the research labs aligned with the flattening of the curve, where we have 30% occupancy of our research staff and faculty in the laboratories. We've developed communities of investigators that can come in the morning. We call them the AM crew, and in the afternoon, the PM crew. Those communities are not allowed to intermix because we wanted to define a community in case there was an outbreak of COVID. As of today, the state, as many of you know, as I just said, Washtenaw County is in phase 4, and we are now moving into the next lab phase 2, where we will be able to increase the occupancy of our laboratories from 30% occupancy to 45% occupancy. And we will be communicating with all the PIs with regard to what does that mean with regards to basically increase the number of investigators you will be allowed to have into your laboratory. We also are starting to back away a bit from developing these communities, and we'll be able to start intermixing the shifts of your research faculty, your research technicians, and graduate students, which are in the lab. We'll also start adding tier 2 clinical trial studies. And a good example of that would be a behavioral study to understand how to modify the diet activity of a type 2 diabetic to increase a more efficient and effective diet. What we're waiting for is the state of Michigan in Washtenaw County to go to phase 5. We do not know when that will happen. We are very concerned with a number of the outbreaks that are occurring in Michigan right now. But when we go to the lab phase 3, which would be concurrent with the movement of the state of Michigan or Washtenaw County into phase 5, we'll be able to increase the occupancy of our laboratories to 60%. We'll then actually be able to add tier 3 studies, and these would be clinical trials. These would be clinical trials such as observational trials of drawing blood to try to develop a biomarker for a chronic disease. And our aspiration, as all of our aspirations are, is to move this to phase 6 with the state of Michigan, which would be post-pandemic. And at that time, we will be able to establish our laboratories as they were before COVID-19 hit the state of Michigan. So this is our strategy. It will move, the ramp up will move according to the phases. If we happen to move back a phase, then we will end up backtracking according to this graph with regards to what is the percent occupancy we'll have in the laboratories. Hopefully, we will only be moving upward. Thank you very much.
Good afternoon, everyone. Let me see if I can advance the slides. There we go. Good afternoon. I'm here to provide the academic update, and thank you all for joining us today. I look forward to sharing with you some of the exciting academic work underway in our medical school. There are seasons in the academic year, and our academic season sort of concludes towards the end of June and begins again in July. So it's really an exciting time for all of our learners as we launch this new academic year during the very, very unique time of a COVID-19 pandemic. Our medical students who stepped out of the clinical environment for a few months have re-engaged in patient-facing activities and did so at the beginning of June. This transition has gone really well, thanks to all of you who have partnered with us to make this happen. Late June marks the start of the residency year for many, many newly minted physicians with a blend of in-person and virtual orientations as we continue to navigate COVID-19. We were also very, very pleased to welcome a new cohort of faculty in July, which was marked with our, as you might expect, inaugural virtual faculty orientation. This month, we will also welcome a new class of incoming medical students and next month graduate students who will engage in a blend of both virtual and in-person learning Our teams are really working very, very hard, paralleling the work that has been done by the research enterprise leadership to envision education for our students in full alignment with campus guidelines. The pandemic affects both our current learners and those we wish to recruit. And this year we have shifted our recruitment efforts to the virtual space. While this may be a challenge, it also affords us the opportunity to think differently about the way we approach recruitment. We are confident that many of these innovative tactics will be useful into the future. We will share more about what we are doing in this space later this fall. We recognize that the pandemic poses unique challenges, but learners are essential to our mission. We continue to provide high quality education in a safe environment for all of our learners in partnership with infection prevention and epidemiology. We have heard that there is some confusion around infection prevention guidelines and social distancing in the clinical environment with our learners. Instead of hard and fast rules, we have developed overarching principles to inform our decision-making. Optimal care is provided by teams, and our learners are essential members of these teams. Therefore, to keep everyone safe, we must customize our care setting to balance the health and needs of our patients, learners, and providers, as well as access to resources. So here are some overarching guidelines. Be thoughtful as to the number of learners participating on a team visit due to increased risk to all members of the team, as well as our patients. When making decisions, consider the educational needs of that visit. For example, to demonstrate an exam finding or to observe an interaction. In general, team visits should be limited to a faculty member with 1 to 2 learners, such as a fellow resident or student. We should all consider how technology might be used to meet educational goals. For example, we might try using an iPad or Zoom to allow the learner to participate from outside the room. You might also consider assigning learners to a subset of patients to allow for an increased number of smaller rounding teams. When it comes to work areas and team rooms, we must try at all times to maintain 6 feet of social distancing between workstations whenever possible. If distancing cannot be achieved in the space, masks must be worn. Masks should also be worn at all times in the open workspaces without doors. And we must ensure there is access to adequate hand sanitizer and wipes to clean up the workstations. So thank you for your attention to all of these guiding principles. And we're happy to answer any questions you have regarding that. I thought I'd shift gears for a moment to talk about our LCME reaccreditation journey. This is the accrediting body for our entire medical school. And we've been on this journey since 2018. It's actually a 5-phase process made much more complicated by, as you might expect, the COVID pandemic. We're grateful to the help of hundreds of faculty, staff, and learners from across the medical school. Last week marked a significant milestone for us. We completed phase 1 of our 2-phase virtual site visit. You may recall we were originally scheduled to have an in-person site visit in April, but that visit was canceled due to the pandemic. Instead, we hosted the site visitors virtually for 2 days last week using a sort of modified, innovative Zoom platform with help from our IT professionals. And we will host them again virtually sometime in the next month or so. We will then receive a final report and recommendation later in 2021. I wanted to take this opportunity to give a shout out to our LCME reaccreditation team who came together to make this extraordinary and unique visit happen. For nearly 2 years, teams of more than 200 faculty, staff, and learners prepared diligently to show the LCME how the medical school not only has met reaccreditation standards, but continues to improve itself in a quest to be better. I want to give a special acknowledgement and shout out to Dr. Raj Mangrulkar and Sarah Weir and their team who worked day and night to help us shine, even during times of great uncertainty. Thank you so much for your leadership and support. You are rock stars, and it's been an honor to partner with you throughout this process. And what you can see here are screenshots of a number of our virtual site visits. So in closing, I wanted to say that you each play a vital role in advancing our tripartite mission and service. We know that we have asked a lot of you, and we are incredibly grateful for your dedication and sacrifices during the last several months. You have been flexible, adaptable, and have shined with the tremendous examples of both innovation and compassion. Especially during these unprecedented times, we remain deeply committed to your success, both now and in the future. For faculty, the Office of Faculty Affairs and Faculty Development is here to support you as you navigate the faculty life cycle. For staff, our human resources partners are here to provide guidance and encouragement as you continue your work towards your career goals. In addition, and I'm really glad Dean EVPMA Marshall Runge talked about wellness. Please make your wellness a priority. The Michigan Medicine Wellness Office offers a wealth of resources that can help you address challenges you may have in these areas. And please do reach out if you are struggling, and reach out to anybody. Any of us are available to help, and any of us can direct you to the right resources that you need. And in closing, thank you for everything you do to make Michigan medicine great. Thank you.
So there's a lot of questions, and I will preface this by saying that those we don't get to, we will write up and put in the daily communication. And I would characterize three large groups here. One is related to masking, some related to the economic recovery plan, and some are just kind of all over the map here. So I'll try and answer those. One is, when will we be operating at full capacity in the outpatient, and what is the timeline to get there? So I'll preface this by saying our current volume in the outpatient clinics is somewhere between 7,500 to 8,500 patients a day, which is actually, we've been running close to about 95 to 98 to 100% of our pre-COVID average, though about a third of those are virtual, which we didn't have previously going forward. But there are still some clinics that aren't quite fully opened, and there's a plan to I think be fully open by mid-August, as they, again, part of this is staffing, part of this is people that were on COVID leave and other things, and as they're ramping up. So that plan was presented here a couple weeks ago by Mike Mulholland, and it's around the mid-August. Is asked if I can provide an update on COVID vaccines, and will we be required to vaccinate? So I would just say that there are several, vaccines, and the ones I'm aware of are mostly RNA vaccines, and there has been some reports out related to the development of immunity in the people who are taking the vaccines. I think there's going to be at least 5 different companies that will be in phase 3 trials by the fall or by December. And then we'll have to figure out that the vaccines are safe and effective. And then I would hope, my hope is that we have vaccines available for us after the first of the year. I don't know that there's been any discussion about requirement for vaccination. I know that if it's safe and effective, I think most of us would want it, though there are plenty of vaccine, advocates across the country who said they won't. I think last poll I saw is a third of Americans said they wouldn't want to take it. It's hard to believe, but if it's safe and effective, I think I would want to take it. But we haven't made any decision about mandatory. I think it's a little early. How will the shift in COVID data reporting from the CDC to HHS affect our ability to understand COVID trends and planning? I don't know how that will affect it exactly. I did confer with Jeff that we are going to continue to send our information both to HHS and to the CDC so that it is in the transparent database. And I would hope that other institutions will across the country also. Does the fall surge plan consider the return of students to the campus in the fall from all over the country? Well, I think that it does. I think the plans, I don't know the details of the plans, but there is a quarantine period for the students coming, but our surge plan is designed to be able to handle a fair number of COVID patients, including students. So I think again, all plans, Eisenhower said plans are worthless, but plans are essential because you still have to make changes when things change, and that's what we've done all along in this COVID crisis. So I'm going to ask masking. Who wants? I think there's a couple masking questions here. Some. I'm going to about the N95s. I have my infection prevention expert. So please clarify the revised policy for use of N95s.
Great. So not a question, but effective yesterday, in accordance with recommendations from our regulatory body, the Michigan Occupational Safety and Health Administration, we did make significant changes to our personal protective equipment recommendations for the care of patients with COVID or those who are under investigation for COVID, i.e. those who are being tested for COVID. The big change there is that instead of having a risk-based model for use of which type of mask you would use, we'll be using N95s for all patient care when we are interacting with patients who have COVID or who are being tested and have symptoms. And the protocols around that are pretty clear in most cases for the inpatient and the emergency department, and really have a lot of detailed work to be done for ambulatory areas. I'll just state this sort of parenthetically that, our risk-based model previously, based upon using a standard medical mask for non-aerosol generating procedure care for usual care, and only using an N95 for aerosol generating procedures, we still believe that that is a safe approach, and an approach that was consistent with the need to conserve N95 masks for the duration of the pandemic. But we are responsible to follow regulatory guidance when possible and when supplies are available. And we believe we have enough supplies to do that at this point. And we hope that we will continue to have appropriate supplies into the future.
So while you're there, do you think this change, I don't know that we've thought about this yet, does this change whether students can see patients with respiratory symptoms?
So I think it doesn't change a lot. I've appreciated hearing from Dr. Bradford about the need to be very thoughtful about why students are going in, what is the learning objective. And so if students are appropriately trained in using N95 masks, both fit tested and trained, and it is appropriate to their learning, then that can be part of their care at the moment. I think that that could change in the future if we have supply chain issues that put us under greater constraint.
Do you want to say anything about testing? If you want to take a testing question, or you?
Yeah.
Okay. It's a little generic. What is the current state of testing, and who can get a COVID test or an antibody test?
Okay. So the current state of testing for the COVID PCR-based testing is based primarily upon a symptom-based approach. And there's an algorithm that's followed for who meets criteria for testing. There is limited testing of asymptomatic persons. And as that applies to healthcare workers, in persons who may have had a close contact exposure, i.e. a household exposure, someone in their household who has laboratory diagnosed COVID, that is offered by occupational health currently. And also anyone who has had an exposure to COVID during the course of their occupational care. Also, we are offering asymptomatic testing of those employees.
And so there are not plans to routinely test employees for COVID. It's risk-based.
Yeah, I mean, I think that all along, and we're seeing this more as there's been a resurgence in cases across the country, there just aren't enough availability to do PCR-based testing for all employees at a regular cadence. We are offering serology testing for our patients who may have had, the priority is those who have actually had COVID-like symptoms but may not have had a PCR-based test to follow up to see if immunity has developed and therefore suggests that they had COVID at that time. We did actually do a fair amount of serology testing through the CDC. I'll share those data with you. I kind of scribbled those down here, but in June, through the CDC serology study, 2,887 employees were tested for IgG to COVID. And those persons who were eligible were those who either had direct contact or care with patients with COVID, or those who worked in those units. So the emergency room, operating room, our ICUs, including the RICU, and including opportunities for those who worked in radiology, environmental services, et cetera. And, you know, honestly, it was surprisingly low. 1.7% of 2,800 employees, so 50 employees had positive serologies. And that broke down to 2% in University Hospital and 0.5% in Mott. So I think that that's a pretty low serology, and it compares fairly similarly with other serologic tests that have been done in other studies among the communities, although we don't have data from Michigan.
Yeah, and the Southeastern Michigan average was 7% with wide range across that. We were at 1.7%.
Yeah, so Dr. Spollinger was just reminding me that we did compare favorably to the other health systems that participated in this study across Southeastern Michigan, where the average was 7%, and there was a range. We were a little less than 2%, but clearly there were hospitals who were much higher.
So a couple masking. Tony, you want to talk about that? This is the policy masking, and he was served on the committee with this president. Thank you, Lorraine. Are masks required if you work in a cubicle more than 6 feet from anyone?
So you have to be mindful. This is going to be a reasonableness test, but in general, indoor in a private space by yourself is where masking is okay. In a bigger space where there are cubicles, distance of 6 feet or more would be optimal, as Carol Bradford noted. However, you have to anticipate that people will be coming in and out. And so conservatively, wear the mask if you know that there's going to be activity coming in and out of a space in order to maintain safety for everyone.
So our masks required in the courtyard and while walking outside from and to parking lots.
So this has been a very active week in terms of executive order, as well as the University of Michigan policy on face coverings. And outdoors for the university, masks are expected and required as long as you're on any of the University of Michigan grounds and properties. And that is all campuses and all off-site locations, such as ambulatory clinics, which is a question I was asked earlier today. The executive order, it speaks to wearing masks outdoors, but if you are able to distance by 6 feet or more, that would tend to be reasonable. So beyond U of M properties, follow the executive order. The U of M properties, follow the U of M policy.
That's all I had for the masks.
Okay, thank you.
So just to reiterate, the president of the university mandated that we all wear face coverings on any of the facilities in any of the grounds of University of Michigan for all employees and visitors. I think we're still trying to clarify whether whether we can enforce this or related to patients who are coming to our parking garages and then walking in, because we typically give them masks as they enter the facilities, but we'll continue to look at that as we go forward. So some of these projected loss today for 2020 was 21 million. June press release was 3 million. Why are these numbers so different? I think that there's a couple one-time items in June that we didn't anticipate. One was a vacation accrual expense. Not that many, during the COVID, not that many people took vacation. And so there's a lot of accumulated vacation. So we booked an accrual. That's really not a cash expense right now. It may, but it's more future. But once you know that it's going to be an expense, you have to book it. So that was actually $8 million. And then there was another couple items, one related to supplies, that the cost of, or the historically inventory, we calculate that, and that typically is a positive, but this year was a negative. And so that was another $8 or $9 million. So there was a number of one-time items, and then there was one item related to 2017 malpractice that we had to book that was unanticipated. So a lot of this was unanticipated, and that's sometimes June is a good month, sometimes it's a bad month because of these one-time items that we settle out at the year end. It says, please clarify how bargain for staff are contributing to the economic plan. Well, I would say for all staff contribute, I mean, if we are furloughing or we're both voluntary or involuntary, or there is a reduction in force, that affects all staff, whether they're bargained for or non-bargained for. We have reached out to a number of the unions to see how they might help. And we have not yet had an answer back from them, but that we'll check. We'll continue to follow up. I think the other two, I think I'm going to take offline. Is there any other questions there? No. Okay. Okay. I think it would be better to answer this in a long email. And a couple things, I don't want to give the wrong answer. So I'm not sure I know completely, and I'll just wait on these two. Okay. Thank you very much for participating. Again, wear a mask, you know, and if you notice friends who are struggling, reach out and help them and give them advice, so that they can get their step back in their gait. Thank you.